Kia ora koutou and welcome to Goodfellow Podcasts. This episode is kindly supported by the Goodfellow Unit. I'm Dr. Louise Kugler, a specialist GP, and I welcome to the podcast Dr. Jo Lang. Today we are discussing novel products of addiction, focusing on Kamini, Barshasha and Cool Lip. Jo is an Auckland Medical School graduate and addiction medicine doctor. She has a background in palliative care and general practice, but has been working in addiction medicine since 2011, with a focus on opioid use disorder. Kia ora, Jo, and welcome to the podcast.
Kia ora, Lou.
So today we're discussing these new novel products of addiction. Can we start with Kamini? Can you tell us what this is in terms of its composition and its traditional uses?
So Kamini is an Ayurvedic medication. So in the same way that you have traditional Chinese herbal medications, Ayurvedic is a medication system that's used in India, and it's predominantly herbal based. It's made in factories. It comes in packaging and containers in the same way that you would buy supplements in a health food shop in New Zealand. And Kamini is one of the Ayurvedic medications. It's a combination product, so it's got a whole list of ingredients in it, and one of those ingredients is raw opium.
So tell us about the demographics of the type of people who are using Kaminis and what are their motivations to take it?
So Kamini, as I say, it's an Ayurvedic medication, and it's promoted and advertised as a strength, stamina, and virility medication. So essentially it's marketed for impotence, but it's also known in the community as giving you more energy and allowing you to work longer hours and be stronger. Because it's marketed very much for men's sexual function, it is only used by men. I have never seen a woman addicted to Kamini. And because of the Ayurvedic elements, it's used by Indian men because that's the group of people who access those kinds of medications and treatments. And almost all the men that we look after are actually from the Punjab region.
So I wonder if there are different names that Kamini goes by. So can you just elaborate on that for us?
So apologies in advance for my pronunciation. So Kamini is a shortened version. There's two different slightly longer ones. So Multani Kamini Vidrawan Ras and Kamini Vidrawan Ras are the two most common names on the bottles. But all of the men that I've worked with have just called it Kamini. If you look in Australian literature, they do talk about people using Kamini in Sri Lanka, Pakistan, general India. In Auckland, we've not come across those populations.
So in Auckland or in New Zealand, where would someone obtain Kamini from?
Traditionally, it was being sold in the Indian superettes. You obviously needed to speak the language, know who had it, know what to ask for. It wouldn't be sold to a 10-year-old who turned up. But people also access it from, if you go online and type in Kamini, you will find Indian websites that sell it, and then they will ship it to New Zealand through the post. So in New Zealand, Operation Poppy happened in September 2020, which was the first community search and seize of Kamini that happened. So prior to that, back in 2013, when we first came across the substance and sent it to ESR and let people know about it, the National Drug Investigation Bureau then put it on their radar and was starting to look for it at the border. They had been seizing supplies of it coming in through the post, but nowhere near all of it. And that was probably one of the dominant ways people were getting it in. But there was one main dealer who was bringing in enormous quantities and then passing it through to the superettes. It is still available through some of the superettes, but I think they're bringing it in more themselves. It is illegal in New Zealand, and I think prior to Operation Poppy, a lot of people did not realise that. But because it contains raw opium, which is obviously a controlled substance in New Zealand, it's not legal to bring it in, it's not legal to sell it.
So Jo, tell us, you mentioned that Kamini contains opioids. Are there any other harmful ingredients within the product?
So when you look down the list of ingredients in the bottle, they're all in Hindi or Punjabi, obviously. One of the ones that is often there is Singraph Soda or Hingula, which is actually mercury sulfide, and it's included as an active ingredient because as part of the Ayurvedic medication system, it's considered to have beneficial effects. And sometimes either as a contaminant or an active ingredient, there's lead. And there's certainly been cases of lead poisoning in Australia and in New Zealand, and people being admitted to hospital when people are taking large quantities of the substance because they've become addicted to it and dependent on it. you're supposed to take 1 or 2 balls once or twice a week for sexual function, not 32 balls a day. And in those quantities, people do run into trouble with the heavy metals.
So thinking about Kamini use for a moment, you did mention some of the indications before, but what conditions or situations might someone turn to Kamini?
So there's 2 different groups of people that I see. One is, so if you're thinking about the Punjab region in India, it's part of the opium trade. So opium moves through there from the sort of Kazakhstan, Pakistan, poppy growing regions. And in the same way that we might use alcohol on a Saturday night as a relaxant, it's not uncommon for a significant proportion of society, again, mostly male, to use opium orally or smoked in a very social setting. And people are not usually dependent. It's recreational. It doesn't cause too many issues, but it does normalize opium as something people reach for the way we reach for alcohol. And then you come to New Zealand, there is no opium available. Kamini is what people can get. And if with the migration process, it's pretty stressful. And if people are finding that they are wanting a bit of energy, they want to be able to work long hours, they need to provide for their family, they're working 60, 70, 80 hours a week, Kamini is one of the ways that people can source the opium that they find gives them more stamina, at least initially. The other group is the guys that get it from a friend who've never had opium before, don't really know what Kamini is, and their friend gives them some and says, this will help you work longer, this will help you with your marital relations, and start using it and then spiral into increasing amounts.
So what signs and symptoms should a healthcare professional look for when identifying Kamini use? And if we detect use, what sort of specific questions can we ask to gauge their use?
Because this is very much contained in a community, you need to be part of that community really to know about it or to access it. I have yet to see anyone who's not male and from India. So the Fijian Indian community don't use it. So you're obviously looking for someone who's in the right demographic. I look after guys from sort of 20 to 75 and withdrawal. So opiate withdrawal looks like having a tummy bug with the flu. So you've got your runny nose and your uncomfortable body and your tummy bug type symptoms if people have run out of supply and have gotten sick. Most of these guys are very good at not running out and not going into withdrawal, and you wouldn't have any easy way to detect it just by looking at somebody. Obviously, if someone's using opiates, pinpoint pupils. But apart from that, if you're tolerant to it, you wouldn't know somebody's taking it unless they're either in withdrawal or you ask them. So the key thing, I guess, is with the Indian community, there's a couple of products we need to be specifically asking about. We'll talk about one of them a bit later, which is the Cool Lip. And just, starting broad and then getting narrower, do any of your friends or anyone you know use Kamini? Is that part of your community? Oh, yes. Okay, well, what about yourself? How often would that be something you try? So avoiding the yes-no questions of do you take Kamini, but certainly the how often, is that something that you would take is useful? I actually don't think you'd know unless you ask.
So Jo, could you just refresh us and elaborate on the key characteristics of addiction and how the process of addiction develops, particularly with substances like Kamini?
So most people don't set out to be addicted. It's not a nice place to be. It's not something people choose. It happens over time. People start when they use the substance for a purpose. So alcohol for relaxation and a bit of a social lubricant, methamphetamine when you're feeling really disempowered. And so Kamini, people are using it for a purpose, either for the stamina and the working long hours or for the marital relations side of it. And initially it's really helpful. You feel better, you've got more energy, you're more relaxed, your anxiety's lower, sexual function improves when anxiety drops, but then it becomes part of the problem in your life. And if you're taking large quantities of opiates, erectile dysfunction is one of the side effects. And then increasingly, particularly because Kamini is short acting, so it's raw opium, lasts 4 to 6 hours, starts wearing off again, people end up needing to take it 2, 3, 4 times a day, and you get into a cycle where you take your substance, it makes you feel better, it wears off, you go into withdrawal, so you're feeling awful, you take it again and you feel better because you've taken the substance that caused the problem in the first place, which is what we see with benzos, particularly short-acting benzos. People just end up in a spiral where it's the only thing that helps doc, and it's like, well, it's helping because it made you sick in the first place. So addiction, you're looking at the 4 C's: craving, loss of control, continuing despite consequences, and an element of compulsion. I've decided not to take today. And then somehow I took it even though I'd made that decision, I don't want it. And it's when it becomes out of control and it's driving your life instead of being something you can use 1 or 2 balls a couple of times a week when you want to have sex, and then it's well under control. And then it just goes from there. Everyone gets tolerant. If you take opiates daily for a regular period of time within 2 to 3 weeks, everyone's tolerant. It's the escalation that becomes the problem. And then obviously if you stop abruptly, you go into withdrawal. It's really interesting. People have had severe car accidents and take morphine for 6 weeks or so. And if they, for one reason or another, run out reasonably abruptly and just stop, they'll often say, gosh, doc, it was awful. I've been so sick and I was just getting better. And then I got the flu. It was a rough flu too, but it got better. And if people don't actually realize what withdrawal is, then they get through it a little bit easier. If they know it's withdrawal, then there's a solution. You take another one and things get better, and it becomes very difficult to stop because of the withdrawal element alone.
Yeah, fascinating stuff, Jo. So thinking about the impact on the individual's mental and physical health, what's the toll?
So Kamini in and of itself, the raw opium component is not that physically harmful. The lead and the mercury and the heavy metals is more the actual concern physically. The biggest issue with it is the short-acting nature. So on-off, meaning you need to take it multiple times a day, and then there's cost and supply. So if you don't have security of supply, there's this constant anxiety of, am I going to run out? Do I have enough? Do I have enough this week? Where am I going to get my next lot from? That takes a huge mental load and distracts people from the rest of their lives. Once you're tolerant, people function pretty well in their life. If you mix it with some alcohol in the evening, you can get pretty sedated, and that means you might not be carrying out your roles. You might not be fathering or parenting as well as you should be because you just sit down on the sofa and fall asleep in the evening. The main harm that we see from this specific substance is cost. Most of the guys come in spending $600 to $800 a week. A few $200 or $300 a week if they're earning much lower amounts, and that's causing them a lot more harm in their family. What we saw after COVID, so Operation Poppy happened in September 2020 and massively cut the supply in New Zealand, and that was the same year that we had COVID. And, India, the burning flames of people dying and the bodies being burnt, most people will remember. So massive supply disruption. The factories weren't working, the shipping wasn't happening, the supply wasn't coming over. And so the price has gone up significantly. So when I used to admit people on 25 to 32 balls a day, I'm now admitting people on 6 to 12 balls a day, but they're spending the same amount of money. And so you can imagine when it's taking your entire wages, the stress that puts on your marriage and, your wife challenging you over where all the money's going. And that's probably the biggest consequence of regular, consistent Kamini use is relationships get very difficult. And there's certainly an increase in frequency of domestic violence related to that stress.
Yes, actually, that was my next thought. What were the broader implications for individuals and their families? So I suppose like all addictive substances, there's a waterfall effect on the families and support networks.
And that's what we see when people come into treatment is their relationships with everybody get better. They come back in 3 months and say, Doc, I bought a car, and in a year or two I bought a house, and my wife is so much happier with me, and I'm enjoying spending time with my kids, and it takes its toll in those areas for sure.
So if we happen to be in our practice and we encounter a patient with Kamini use who's showing signs of addiction, is this a situation that we should be managing or could be managing in primary care, or should we be referring them on to specialist services?
So opiate use disorder is one of the few addictions that we have effective treatment for that is both financially to the taxpayer of New Zealand, amazingly effective, and to the person and their family, also incredibly freeing. So it seems really counterintuitive. Somebody has a drug use disorder and I'm going to put them on prescribed drugs. So what are we doing here? But for every dollar spent on a service like opiate substitution treatment, we save 12 to the community in health costs and people going back to work and paying taxes and just across the board. And that was back in the late 90s when they last did those kinds of analysis. So whilst you can work with somebody if they present saying, I have an opiate use disorder, not their words obviously, I use Kamini and I can't get it and I want to come off it, you can certainly work with them like you would with alcohol about cutting down, gradually weaning, nothing abrupt because you'll get sick and you won't be able to function. You can cold turkey and go, white knuckle through it if you really want to, but most people don't tolerate that and they don't stay off. But the honest truth is the best treatment for these guys is to send them through to your local drug and alcohol service. There is opiate use disorder treatment throughout the entirety of New Zealand. There's 23 different services, one for every previous DHB. And we provide substitution medication that allows these guys who usually come in with a lot of recovery capital to do really well. And then once they're settled and once things are going well, they can come back into general practice in a shared care arrangement where you might prescribe their medication for them, but we manage any changes that they might need in the future.
So, Jo, I wonder if we can talk about a small subset of people where we may, as primary care practitioners, be exposed to. And those are people who are already on some kind of treatment plan for addiction, who are temporary visitors to New Zealand or on temporary residence, perhaps RSE workers, and we're asked to prescribe for them. What are our obligations and are we able to prescribe?
Thanks, Louise. So in New Zealand, prescribing for the purpose of dependence, so addiction, is very legislatively constrained. The General Director of Health, John Crawshaw, has to gazette a service to say that we're allowed to prescribe for the purposes of dependence, and then we authorise GPs to prescribe for this person at this pharmacy on this medicine at this dose on this takeaway regime, and there's no ability to really move from that unless we produce a new authorisation. So when somebody comes over from India and they've got an opium use disorder in India, they've been established on buprenorphine, there's almost no methadone over there, so it's all buprenorphine, and they come to New Zealand, it's called Adenok is the brand name in India. They come to New Zealand, they're on 4 milligrams or 8 milligrams, they bring in their script from India, they bring in their packet of medicine, usually they've only got a couple of days left, and they say, can you prescribe this for me? They know they're here on a visitor's visa and they'll have to pay for their medicine because they're not entitled to healthcare. It doesn't seem unreasonable, they're established on this, you're going to prescribe it, but then they take it to the chemist and the chemist says, you can't have this. This is a medicine for addiction. You're addicted, your GP can't prescribe for you unless they're authorised by gazetted service, and it gets really messy. So the message is, if somebody turns up to you on buprenorphine, naloxone, Adenok, Rincads, urgently, especially if they've only got a couple of days left, we need to get a copy of that prescription, hopefully see them if we can, possibly do an interim prescription for a week, and then get them in to see us so that we can carry that on while they're in New Zealand. Usually we don't hand them back to GP shared care if they're only here on a temporary basis. We'll just prescribe for them while they're here. When our guys go over to India, they can source buprenorphine over there, and I've had the odd person who prior to COVID was going once a year and buying a year's worth of buprenorphine and bringing it back to New Zealand, and then obviously COVID hit and he couldn't do that and had to turn up to us urgently.
That's wonderful advice. Thank you, Jo. And I know working in after hours, particularly in the telehealth world, we get a lot of these requests because they can't get into their GP in a timely manner. So good to have some advice there, and thank you for offering to see them in CADS. That's fantastic. So are there any obligations legally or ethically for us as healthcare professionals to report suspected or confirmed Kamini use?
Not that I'm aware of. There's certainly no, if somebody comes to you and they're a nurse or it's no different to any other time that you have someone, a veterinarian, who could be accessing opiates through work. So just to think about, what do they do for work? Is this safe? Driving heavy machinery, and so giving them advice that, in the same way that you can drive on opiate treatment, providing you're on a stable dose and not taking any other substances, the actual risk, providing people are taking the same amount of Kamini at the same time every single day, is actually reasonably low because they're tolerant. It's when people take 2 balls 3 times a day, and then in the weekend I take 12 and I get a bit sedated and a bit out of it and I add some alcohol, then that's the point where they definitely shouldn't be driving, shouldn't be operating heavy machinery. But most of these guys turn up in a pretty functional state, except for the harm it's doing to their family and their finances.
So you mentioned opioid substitution. I wonder if you could briefly discuss for us what that looks like and how effective it is for those struggling with addiction, particularly in the context of Kamini.
So opiate substitution treatment, OST, is amazingly effective. Within 6 weeks, somebody can go from a very distressed state where everything in their life is falling apart to actually being considerably better and life is good again. But the reality is they're still opiate dependent and they'll still be with us in 5 years' time. But in the short term, it's Unlike alcohol or methamphetamine or cannabis, where you just have to stop. There's talking therapy and there's a few medications that help a bit, but largely you have to stop. Opiate substitution is, we're going to take you off the short-acting opiate where you're up, down, all over the place, to a really boring opiate. There's no intoxication. There's no withdrawal. You're going to feel the same morning, noon, and night. We'll give you really even serums, and you only have to take the medicine once a day, or with the buprenorphine. So methadone's once a day. Buprenorphine is a partial agonist. It's really long half-life, and people can actually take that every second day. So we've got these alternative medications where we're not asking your brain to adjust to being without opiates. We're not asking you to go through withdrawal. We're just going to take away the up-down intoxication withdrawal cycle, and we're going to remove the financial aspects. So we're giving you a free, legal, much safer medication that you take once a day, observed at the chemist to start with, so we know it's you taking it, not anybody else, and that you're getting the right dose at the right place. And we take away that anxiety of running out, because your medicine's always available at the chemist tomorrow. I don't need to worry about sourcing it. I don't need to worry about using it all today and having none left for tomorrow. And then as people settle down and they get their internal control back, then we will start adding some take-home doses. So they might go to the chemist 4 days a week. And then if things are going really well and they get to general practice prescribing and GP share care, they might be going twice or even once a week to consume and then pick up their medication for the rest of the time. And to ask somebody to come off their substance that they've adjusted to and they've got neuroadaptation and their brain is now very much settled with this is my normal, is very, very challenging. And the relapse rate, if people do wean off opiates within 6 to 12 months, is anything between 50 to 90% relapse back to opiates. And the relapse is where we lose the gains. We lose the housing, the relationships, the job, and the risk of overdose is huge, which is what you see with all the actors. They go into rehab, they come off their substances, they relapse, and they overdose and die because they've lost their tolerance. So, I mean, I've got an aging cohort on opiate substitution treatment who all expected to die young, and now these guys are 60 and 70, and it keeps them alive and keeps them well. I say to people, if your thyroid didn't work, you take thyroid hormone. If you have diabetes, you take insulin to replace it. And if your brain is now adjusted so that its new normal is to have a certain amount of opiate in your body, then we just need to provide you with your opiate medication to keep you in that comfortable, stable space, and then you can function. I've got people driving trucks, teaching high schools, some very high-powered jobs, and doing really well. The key thing is recovery capital. So if you come in with an education, married, working, with sort of a single isolated substance, then I can be pretty confident you're going to come out of this in a really good space. If you come in with polysubstance use situation, you might have started using at 10 or 12, you've got very little schooling. I know your life's going to be in a better space on treatment, but from the outsider, it may not look that much better. You may not be working, but a lot of these guys, one of my chaps has spent a very long time in prison, most of his adult life, almost every Christmas. And since he came into treatment, he has not been back into prison in the last 7 or 8 years. So the savings to the community from having to not keep him in prison is huge. And he's happier and his life is going better, even though externally it doesn't look that great.
It sounds like such satisfying work, Jo.
We make a huge difference, and being able to offer something to people that I know works is pretty powerful stuff.
So let's just move on now to the last thing that I wanted to talk about, Barshasha and Cool Lip. So I wonder if you can just tell our listeners about these two things.
So they're quite different. Barshasha is actually Kamini, but it comes from the Yuani medication system, which is more the Persian region. I've only met 1 or 2 chaps who've been using it, and usually when they can't get Kamini, it's a paste. It looks a lot like Marmite. So it's just if we're using names for opiate-containing substances that people use as kind of a herbal self-treatment medication that they might source over the internet through post and buying online, Barshasha is the other one. Cool Lip's a whole different thing. So Cool Lip is a brand name. So just like Jandals in New Zealand for thongs or flip-flops. And it is tiny little tea bags that contain tobacco and a whole bunch of other chemicals and substances. And you put them in your mouth like a NRT lozenge or gum, and you park it in your buccal space and you get a nicotine hit. It's the more modern version of chew tobacco, where the guys would take tobacco and chew it and then park it in the buccal space to absorb the nicotine and then spit it out. So Cool Lip comes in a packet of 10 to 20 little tiny tea bags. You put it in, wet it release it, it makes your lip go a bit numb. And it's a very, very fast nicotine hit, much faster than NRT lozenges, which take, 20 minutes to really kick in. These things, you're feeling it within a few minutes. People can be using a packet a day, so 20 a day. Its cost, again, it's not as expensive as buying cigarettes in New Zealand with all the tax, but it's not cheap either. So it's essentially a no-smoke tobacco. The main issue is mouth and throat cancer, lip cancer, and damage to the teeth. So it will eat the bottom of your teeth where it's lying against it a bit over time. Most of these guys do quite well with NRT lozenges and gum because it's the same delivery mechanism. Obviously, they're free. The cancer risk is either nil or minimal, but it doesn't quite feel the same. So people have to be a little bit motivated to change over, or at least use those to cut down their Cool Lip use. The other name it's often known by is Kenny. Kenny tends to be more the older chew tobacco that you put in, and Ansel, but I haven't seen as much of that. Mostly if you say Cool Lip, people know what you're talking about. So I tend to not ask about tobacco use anymore. I ask about nicotine use, because that covers, so how much nicotine do you use? Vaping, tobacco, Cool Lip, Kenny, smoking. The other thing would be hookah and shisha, which people do in more of a social setting, is the other place that this community will use nicotine. So I tend to reel off the list of them when I'm asking about people's nicotine use.
Thank you for clarifying that, Jo. That's just fascinating and opened my my world a little bit wider today. So thank you.
Probably the one other thing to think about with Cool Lip, just thought of it, it's not legal to sell in New Zealand. So the situation with tobacco and nicotine-containing products in New Zealand is that you can import them legally for your own use. So people can buy these online and get them posted to them. But once it's in New Zealand, it's not legal to sell. And they are sold in the Indian superettes where people also buy Kamini or people import it.
Great. So thank you, Jo, for your time today. It's been a really fascinating episode. Just to conclude our podcast, some take-home messages for our listeners, please.
The biggest message is that methadone and buprenorphine work. If you've got somebody who's struggling with any medication or substance that contains opium in New Zealand, reach out to your local CADS or other OST provider in your area and have a chat with them. The patients do really well when they come and see us and get started on treatment. Kamini is a particular subset of people with opiate use disorder that I look after that clusters very much in a particular region of the world, and people who come from there, it's part of their normal medications that they self-treat with, and a small proportion of them run into trouble. Many of them can use it recreationally or appropriately, and it's never a problem, but like everything that's potentially addictive, a small group will run into issues with it, and for those we can make a massive difference.
Wonderful. Thanks, Jo. If you're a New Zealand GP and would like to claim CPD points for listening to this podcast, our podcasts are eligible, so please log them. You'll find a list of resources used in this podcast at goodfellowunit.org. Thanks for listening.